Again. Ready? You're on.
All right, my name is David Walker. Here's the problem. Orthopedic surgeons don't know how to treat each patient specifically, meaning there's an implant they put in the joint, and they can choose the size as well as where to place the implant with respect to the bone, right, to improve the patient's outcome. We're after improving outcomes. The solution is we provide a software that allows the surgeon to know exactly what size and what placement to use for each patient, whether it's you or me, right, so that I can optimize the best outcome for the patient. Currently, we're working with implant manufacturers such as DePuy Johnson & Johnson, Zimmer Biomet, Tournier, and we're leveraging our technology, this software, to help them improve their implant design. To date, from the beginning of 2015, we made $105,000 in working with them doing that. Right? They're really interested in this preoperative planning that we're developing because it's predictive. It's actually predicting functional outcomes. So it's not static, it's not just dead. That's the current state. So we're actually predicting outcomes. Now we want you to partner with us to do that. Thank you. Thank God for 20 minutes.
And 20 minutes, ready to go.
Good afternoon. My name is David Walker, and I am CEO and founder of Rehoboth Innovations. And we focus on improving patient care in orthopedics. Now, the question is there a need for this? Aren't patients getting the best care? You know, you have expert surgeons, bless you. You have expert surgeons who do surgery. Well, let's take this gentleman, for instance. On one hand, he's very happy with his outcome. On the other hand, not so much, right? Now, the question is why? Is he the only person who's unhappy with their outcome? No. 1 in 4 patients who receive a joint replacement like the one you see here are unhappy with their result. Why? They can't use the bathroom, can't drink coffee. Functional tasks they can't do. I'm sure one of you have a grandmother or someone who has either a knee or a hip or a shoulder, right? So we want to restore functional motion to these patients. Now just to give you some stats, 16 to 68% of shoulder surgeries have complications. So complication rates can be as high as 68%. Now the question is, why are these complications happening? Well, let's step into the OR. You have a fellow surgeon and a resident, right? And they're putting in a joint replacement into this person. And so they have a choice to make. What size implant should I use? And where should I place the implant for this person? Right? They have 4 or 5 different sizes to choose from. How do I know one size is better than another? Well, they don't. Right? That's why you fly across the country to the guy who's done 1,000 of them, right? Because he has the best feel and hopefully he'll give you the best outcome. That's still qualitative, that's still field-oriented surgery. That's what our software, our technology is going to get away from. We want to reduce complications and improve outcomes. How are we going to do that? Well, let's start here. 8 years ago, I started at the University of Florida collecting different data for the University of Florida Shands Orthopedics. And what we did is we had a study funded by the American Shoulder and Elbow Society. And we collected motion data and force data on muscles. And particularly on patients who had that implant inside their body. So we actually measured the response, right? How did the body respond to this implant? Could they still move their arm? Could they not? We measured that information. We quantified it. Okay, we took that information and created a virtual model of each of these patients. And then we took that virtual model and ran it through different simulations, like abduction, raising of the arm, internal and external rotation, all these different activities, and then predicted functional outcomes, how the muscles would function. Because the IRB, Institutional Review Board, for those of you who don't know, they won't let us just cut people open, right? So that's why we're using virtual modeling to tell us information we don't know. So where does that put us? It puts us in a place where we can take something like this joint, shoulder joint, and we can predict the red lines of the muscles, that if we change the implants you see in there with respect to the bone, we can predict how the changes would likewise affect the muscle function and the outcome of the patient. All right? So again, it's size and placement that has an effect on the outcome that surgeons see. So we're predicting that objectively and quantifiably. Now that sounds really great, right? How are we applying that software? In several different applications. Again, I gave you the stats that we made $105,000 reevaluating implant designs and manufacturers currently. So we know our market pretty well. We also developed this preoperative planning tool because honestly, there are a lot of surgeries being done and a lot of surgeons who have uncertainty as to how to treat patients specifically. So, and these are other applications that we foresee the software being used for, right? And the question is, Well, what about your competition? What's going to be your competition? Well, surgeon, first of all, right? The field. I know what I'm doing. Do I need this? Well, shoulders in particular is a younger market. They're in the third generation of design. So surgeons are a lot more open to receiving new technology and insight, especially when they know there's something that there's a common consensus that they don't know. And I give you an idea of what I mean. Tom Wright is an expert surgeon who runs upper extremity orthopedic clinics. Tom Wright is one of my advisors. Tom's OR time was the premise for why all this started. Tom knew, he's done thousands of them, but he knew, I don't know, David, I don't know if this woman's going to be able to lift her arm or not. I don't know how to treat this person versus that person. I've done a lot, so I have a kind of feel, but I honestly can't give someone an idea of how they're going to perform after surgery. Okay? So the need came from the surgeon. So that's kind of how we overcome that competition. We have a group of surgeons who are experts and designers in this area who literally, they're backing us. Okay? Secondly, manufacturers, they already have a preoperative planning tool. Stryker has a preoperative planning tool. Well, why do we need your tool? Well, it's not predictive. It's static. The surgeon looks at the x-ray, says, Stryker, you need to put it here. Stryker says, we can get you there within a millimeter. Say, okay, that's great. But is here the best place? Think of it like this, a GPS versus, an address. Where's the address? You can use any GPS, right? But you need an address, right? What's the best address for you versus me? So that's how we overcome them. Other simulation companies, same thing. Everything that we're talking about is non-predictive. And so that brings us to our competitive advantage. We predict patient outcomes. That is the main thing. Right now in our area, we're the only niche company to do this in orthopedics, right? People do preoperative planning. They do. But they don't predict muscle function. They don't predict functional outcomes. Now, again, with that sort of information, you can reduce surgical time. On average, we've been doing our validation studies now about 10 to 15 minutes. So obviously, there's cost savings to people. We have copyrights and trade secrets. High barrier to entry. I spent the last 8 years developing this in a highly collaborative nature with partnerships with manufacturers and so on. So our barrier of entry is high. Our team expertise, we have a lot of expertise. We've published in the Journal of Shoulder Elbow Surgery numerous occasions, our modeling, our technology, and we have surgeon partnerships. And so I mentioned all that, but is there really a market, right? You tell me one surgeon, what's the market? Well, almost 1 million joint replacements are being done a year. 100,000 of them are shoulder surgeries, right? $9,600 it costs you per implant. So there's a huge market here. Almost a third of the U.S. economy is in musculoskeletal related issues, right? So there's a huge market here to provide insight to meet the need. What's our channel market? Well, our business model is we're going to license this to manufacturers, right? They have thousands of surgeons already on as a customer base. We're going to license it through them, and we're not going to hire 1,000 people. They'll provide it to the end user. So the manufacturer, hospitals, those are the guys that are actually going to be paying for the software. And so this strategic relationship, like I said, previous us to the surgeon database of thousands of surgeons without all that back end of getting hiring a sales force. So, this is all hypothetical, no. Like I said, we made $105,000 since the beginning of January. These are all our customers currently. The P. Johnson & Johnson, Zimmer. I put percentages next to their names. Why? That's the amount of the market they own. So you're talking about 82% of the market in the shoulder owned by our current customers. Now, I wanted to give you that before we get here, right? Because this is the voodoo, right? Black box, how are you going to make millions of dollars, right? The question of how valid this is. So these are our predictions for 2016. This is what we made as of today. This is what we expect to make now that we've launched our actual server and our software in both the implant design tool and the preoperative planning tool. Okay? And so, just to walk you through this a little bit. 2 projects a year, that's on average. That's pretty realistic with each company we work with. That's about how much we charge per project now. We've inflated our prices a bit because of the value that we bring. Preoperative planning wise, I said over 100,000 shoulder surgeries done a year. This is a quarter of them. There's probably more RTSAs being done. We took 10% of the market, charged a $410 fee for each plan. That's nowhere near what regular planning costs. It's over $1,000 for currently the charge for a regular plan. So I'm pretty confident in those numbers. My background, I have a PhD in biomechanics and mechanical engineering. I've spent 8 to 9 years developing this technology over my course of my dissertation and now on to publish it and move on to building this company. My advisors and these men here are all experts with at least 20 years in their respective areas of expertise who are now currently have helped me build come to this point, and we are a member of the UCF Incubator. Now, where I'll leave it here with you guys is we need your help to improve orthopedic surgery for forever, basically. Predictive planning, right? You want to give someone insight as to how they'll perform, how they'll do, whether they'll be able to return to playing tennis, drinking coffee, and that's what we intend. Thank you so much for your time, and I'll feel any questions you may have.
We're slightly over 9 minutes, just like we get, so you have lots of time to work with, just to, so,
Question. Okay, so this weekend I was out cutting seed pods off the palm tree and I needed the shoulder, right? Without this, when and Dr. Bruce, he says, yep, we gotta do a shoulder replacement for you. At what point in time will they determine under current methods, at least beginning sizing and position, will they put me through some stuff ahead of time before they get me into surgery to at least have some, options laid out on the table next to them?
Okay.
Do you understand the question?
Absolutely.
Okay.
When are they going to determine what treatment to use for you? Right? Is it going to be when they bring you in for clinics? Is it going to be when they take your pre-op CT? Or is it going to be when you're in the OR?
Right.
That's what you're asking, right?
Well, I want to know now.
Before you get there.
I want to know, they're going to take me to surgery. Surgery
know-
is the answer.
Okay, do you know what implant they're going to use?
Well, I want to know how they decide, and I'm trying to
If you
get
have-
your value
Okay.
into this eventually, but I got to understand how they do it.
I'm going to give you the information so you know. If you have a remaining rotator cuff, they'll oftentimes go first for the total shoulder replacement. Okay? And I'll show you exactly what that looks like so that you actually have an idea of what that looks like. Let me see here. If I can slide that in here. Presentation. All right, perfect. So you either have this implant or this one. Okay, this implant is for people who still have remaining rotator cuff muscles. Okay? So they're saying, okay, if you still have remaining rotator cuff, you just have osteoarthritis and wear, right? So because that's just still wear, we still have the muscles to drive the motion, right? So they'll go here, right? If you're automatically, because it's probably a cuff issue as well as some osteoarthritis, if your cuff is wearing, they usually go to something called a reverse. And what you see those screws in the ball, that's why they call it reverse. They just reverse the geometry, as you can see here, right? But they screwed into your scapula, right? So that's how they're going to make a choice. Based on where your musculature is, they're going to make a choice of whether or not to use a total or a reverse. Now they can see that from the pre-op CT based on how much wear you have on the joint. So based on the spacing here between the scapula and the humerus, they see what the spacing is. If they see you have a lot of wear, that means you have a lot of osteoarthritis.
Let me shorten this question. Let's assume that they're going to do this thing on the
Okay,
right hand
perfect.
side. They know going into
Okay,
surgery.
okay.
Will they have already selected and have it in the operating room the implant?
No,
Okay. all right,
no. So what you'll have, I'll tell you exactly what you'll have. And this is why there's a need for what we do. Because the surgeon is in there.
Your needs, yeah.
Yeah, because the surgeon opens the tray, he has 7 trays.
Yeah.
And there are 5 different sizes of each of those implants.
Okay.
So you can imagine, right? The ball has 3 different sizes, right? The polyethylene insert, this has like 5 different thicknesses, right? The tray has different thicknesses. So they're trying to couple all those parameters to get your tensioning right, okay? That's what they call it. They want to effectively lengthen your deltoid muscle to the proper tension, but who knows what that proper tension is at the same time? That's why there's a need for us, right? To know for you specifically what's that proper tension.
So with Rehoboth,
Yes,
same scenario.
absolutely.
And before we get into the operating room, what have you done to
I've
minimize this
already taken the uncertainties.
size and placement
Issue.
business?
Yeah.
What have you done?
I've taken your x-ray, your pre-op CT, and I've created a virtual model of you.
Okay.
I've taken strength characteristics from your side that's healthy.
Right.
So we know your strength as well as your anatomy. And now from that information, I created a virtual model, much like you saw here, right?
Yeah.
When I showed you this, I created a virtual model of you, and then we simulated thousands of surgeries. We simulated every place you could possibly put the implant as well as every size you can use. And then we said, what's the best placement for caddy? And we took that solution, and then we planned out that solution for you.
And size too.
And yes, so that the size of the implants included as well as where to place that implant. But also, this is another nuance. He gets in there and he finds out, well, she's still tight. Her muscles are still tight. Soft tissue. I can't get to where you're telling me. So now it's interoperative as well because we run all the simulations before we ever get in there, right? In that space. So now he said, David, I can't get this high. I can only get this high. What's the best solution in that box? You understand what I'm saying? Because exposure constraints are a real issue in the OR. And they're costly for time-wise and for implant waste. Okay? So we offer that value as well. So it's not just a solution that if you can't reach it, then go back to the drawing board and let me do the field. No. We have the first best solution, second best, fifth best, 10th best, until you get to it. So we have that information so that he can optimize your range of motion.
When he does that, when he said, oh, David, I can't get that high now that I've got her open,
Yeah.
is the option that you're going to recommend for next on the table?
Yeah.
He's taking...
Absolutely.
Okay.
So that's another beauty. So this software integrates with current devices,
Right.
current prostheses. It's not that we're creating a whole new prosthesis. We're saying, well, the pew has these 5 different sizes. Okay, we dial into the pew sizes here. Okay? And we're saying, with what you have on the table, this is how you get your best solution.
And does the doctor usually select the manufacturer, like the pew?
So they will. They will, usually. That's but healthcare is changing. So we're currently building a collaboration with Florida Hospital. And what you see in the more private segments of the Adventist Health and other hospitals is that now they're saying, listen, there's an amount of cost that I'm paying per year for the implants. And what we want to do is carry the same implant no matter which doctor it is. No matter how many doctors you have, we're going to carry the same implant so to get out of this thing where I know the sales rep, we have a very good relationship, so I carry this implant. Not absolutely sure it's a better implant than the other one,